very good morning to all. Thank you, Kedar, for the introduction. Thank you, Nagarjuna and team Yashoda. Trust me, the Hyderabad airport authorities now know me by face. Number of times I have come here. And I would like to thank Dr. Balaraju, who's helped me with this slide set in particular. Most of my job is already being done by the previous speaker, wherein the radiological aspect of all the mediastinal nodes has been covered. So I'll be revising most of it again and also explain you how these nodes will be visible when you are inside the trachea with your bronchoscopic view. So we'll be first starting with the question. Question goes, which of the following lymph node station is not approachable by EBUS TBNA? Options.
I think without the options, Pradeep would have answered it, so I think it would have been fixed.
Okay, so it's slightly more complex than what. So we need to scan the QR code. I believe you need to join the Wi-Fi because at least for Vodafone, I realize the network is weak over here. Yeah, so do I need to do something? Yeah. So those are your options. Which of the following lymph node station is not approachable by EBUS TBNA? The 4L, the 5, 6, both 5 and 6. I believe no confusion over there. So both 5 and 6. Mind you, we are talking about transbronchial, not transvascular. Correct answer is D, both 5 and 6. And okay, the second question is also here. So station 4R and 10R are demarcated on EBUS mapping by which of the following? A, the aortic arch, the left pulmonary artery, the azygous vein, or none of the above. Correct answer is the azygous vein. So we have a new champion for this quiz. Okay, so now coming to the anatomy of mediastinal lymph nodes. So for the beginners, most probably what you will be encountering is the station 7, the 4R and the 4L. So a lot of emphasis is on understanding the borders for 4R and 4L, and otherwise the major landmarks that you need to know is what you see. So the major landmarks that you need to keep in mind is A, the azygous vein over here, and these two structures, the aortic arch and the pulmonary artery. So this is how the anatomy looks like, and these are the major vessels that cross the bronchial tree at the level of carina. So as explained by the previous speaker, this is the classification of the lymph nodes. So these are the superior mediastinal nodes, that is the 1, 2, 3, 4. Then the aortic nodes, these are 5 and 6. The inferior mediastinal, that is 7. And of importance for a pulmonologist are then the 10, 11 and 12. So these are the ones which are approachable by the EBUS TBNA. This set 5 and 6 is not approachable. And then there are these nodes which are approachable by the EUS-BFNA, which will be explained by another speaker in the due course of the event today. So the normal mediastinal anatomy, so this is how the mediastinum is divided into the superior mediastinum, the anterior middle and the posterior mediastinum. So when you approach your patient with your EBUS scope or a normal bronchoscope, this is how your bronchoscopic vision would appear to you. You are right now at the level of carina, and the carina is demarcating into the right main bronchus and the left main bronchus. Subsequently then dividing into the upper bronchus and the left upper bronchus, and these are how the vessels are placed around you. And as you introduce your scope into either the left main bronchus or the right main bronchus, this is the anatomical correlation of the vessels and the lymph nodes. So I will be explaining each one of these. So that's your normal CT anatomy. So station 1, as described, the upper border is the lower margin of cricoid and the lower border is the clavicle and upper border of manubrium. It's after the station 2 wherein you need to understand one thing which you need to keep in mind, that the demarcation between the right and the left does not belong to the center of the trachea, it's on the left border of the trachea. So whatever comes anterior to the trachea, even if it is at the center, will be considered as the right side nodes, and everything that is lateral to the lateral border of the trachea will be your left side nodes. So the demarcation for the right and left does not lie in the center of the trachea, but on the lateral margin, left lateral margin of the trachea. So here you can see this is your image over here. This is your 2R and 2L. So as explained by the previous speaker, this is the radiological and anatomical borders, but here you can see these lie somewhere at 2 o'clock and 10 o'clock. So these are the main hands of your clock. So when you are looking at the 2R, it's at 10 o'clock and 2L is at the 10 o'clock position. Then the next set of nodes is the 3A and 3P, the prevascular and prevertebral lymph nodes, which are not approachable by your EBUS scope. Now coming to very important and very commonly approached node is the right lower paratracheal. The upper border here is the intersection of the lower margin of innominate vein and the lower border is the azygous vein. So here you can see this is your 4R node, and you will be progressing beyond the innominate vein and then approaching the 4R node, which will have a lower border demarcated by the azygous vein. The second important node after the 4R node is the 4 left paratracheal node, where you can see that there is a very clearly made out Mickey Mouse sign. Can you appreciate these? These two ears are the ears for the Mickey Mouse, and this is your lymph node. This is one picture that you need to keep in mind whenever you are approaching the 4L node. So basically these nodes, as you can see in this diagrammatic representation, will be demarcated by the aortic arch and the pulmonary artery, which are visible here as the two ears of the Mickey Mouse, and that's your 4L node. 5 and 6, as we had explained in the quiz, these are not approachable by the transbronchial needle aspiration route. Subcarinal is the most commonly sampled node, and these are located caudally to the carina of the trachea and are not associated with the lower lobe bronchi or arteries within the lung. On the right side, it will extend caudally to the lower lobe of the bronchus intermedius, and the left side, it will be the upper border of the lower lobe bronchus. So here you can see this blue colored, this is your station 7. So you will be most probably approaching the carina either from the right side or from the left side. Your scope will be now facing medially towards the wall of the trachea on the carina, either at, if you are approaching from the right side, it would be somewhere at 9 o'clock, 10 o'clock or 11 o'clock position, and if you are approaching through the left main bronchus, then it would be somewhere at 2 o'clock and 3 o'clock position. Station 8 and 9, these are the paraoesophageal nodes and pulmonary ligament nodes. So the previous speaker has already covered the radiological anatomy. Another set of nodes which are approachable by the EBUS TBNA and quite commonly sampled are the station 10R and 10L. So here you can see the demarcation between the 10R and the 10L will always be the azygous vein. So very important landmark to differentiate two nodes on the right side, that is the azygous vein which will demarcate the 10R and the 10L. Similarly, when we are talking about the 10L node, the upper border will be the upper rim of the pulmonary artery on the left, and the lower border will be the interlobar region somewhere over here. So on the right side, your demarcation is the azygous vein, and on the left side, the demarcation is the pulmonary artery, which will separate the second and separate the fourth and the 10th set of nodes. So this is the bronchoscopic image here you can see for the 10R, and this is the bronchoscopic image for the 10L. Now going further, we will have the right superior interlobar, that is the 11RS, and the right inferior interlobar. So here this is between the right upper lobe bronchus and the bronchus intermedius, somewhere over here, and the inferior is between the middle and the lower lobe bronchus on the right side. So you can see here your scope is now facing the lateral side, you are scanning the lateral border of the right lower lobe bronchus. So this is the area which you need to scan for the 11R and the 11, both the set of 11R nodes. Now coming to the 11L, this is between the origin of the left upper and left lower lobar bronchi. This is your area. So here you can see this is the left upper lobe, this is the left lower lobe, this is the secondary carina in the left bronchial tree, and that is where you will be scanning for the 11L nodes. So these are the 6 landmarks as we had discussed. For the 4R, we have the azygous vein over here. That's your azygous vein. So above this is the 4R and below this is the 10R, and on the left side this is your 4L and 10L. Above this will be the aortic arch, and this will be your pulmonary artery. So this is a compilation of all the EBUS TBNA approachable nodes. So when you will be attending the workshop, what you need to understand is how this is how your EBUS scope basically is introduced into the trachea. So you are going from the proximal to the distal end, and this is how your ultrasound probe is scanning. So this image is basically placed on a clockwise manner, and this is how it is visible in your EBUS ultrasound monitor. So this is your proximal end, and this will be your distal end, and this dot here specifically is for your entry of the needle. So just for the image orientation, here we can see this is the 4L node. This, in this section you can see this is the 4L node, this is the aortic arch and the pulmonary artery. So that's how your scope will be scanning the nodes. So a quick revision, these are larger images of the same. So this is for your station 2 nodes, which is the 5th tracheal ring, the 4R and 4L which we have discussed before, station 7,
Samir, you have 2 more minutes.
Yeah. So a short quiz which does not need you to scan any QR code. So you need to identify these nodes. Can anyone tell me which is A and B over here? A is so A here is 2R and B here is 4R. This is the most easiest one. Can anyone tell me this set of nodes? Is this station 7? Yes. So that's your station 7, that's your 4R. So this is a set of nodes which is lying between the aorta and the left pulmonary artery. Are we looking at 10L or 4L? So this is the 4L. Now we are inside the right main bronchus. Any comments on these two? This one is 10R, this one? Yes. I suppose this is the last one. What are we looking at here? This is the secondary carina. That's your 11R. Now we are inside the left. Any comments over here? That's our 11L. So a lot of this is something that you will catch up more with practice. The more you scan the nodes either on a model or inside a patient, is the more you will get proficient with understanding these nodes. But what you need to know basically is the placement of the station 7, 4R and 4L. So on behalf of VABIP, I would like to take this opportunity to invite you to become a member of VABIP. And VABIP itself has started a official fellowship program in Istanbul, for which you just need to log into vabip.com. I'm thankful to my friends and family. That's a code that I follow. Go alone if you wish to go faster, and go with your people if you wish to go longer. Thank you.
Thank you, Samir, for that lucid presentation. I think if there are questions, we'll take it. Otherwise, we'll move on to the next speaker in the interest of time. Are there any questions? Yeah, so I think Samir is very clear. There are no questions. So let's proceed with the next speaker. Thank you, Samir. Thank you so much.
The next speaker for the session is Dr. Gopi Srikanth. He's a head of gastroenterology unit at Yashoda Hospital. And he'll be talking on the topic of anatomy of mediastinum through the esophagus, the USB view. Thank you.
Good morning, everyone. I am Dr. Gopi Srikanth, Consultant Advanced Endoscopy in Yashoda High Tech City. I thank Dr. Nagarjuna and the organizing team for the opportunity. Now we have seen the mediastinum through the eyes of CT and EBUS. Now let's see the mediastinum through the eyes of a EUS. So coming to the applied anatomy, the esophagus is the station through which we are going to do the EUS. So anterior to it is the trachea and its bifurcation, and comes the aortic arch. Then there is the pulmonary trunk and its branches, and this is the venous system of superior vena cava and inferior vena cava, and lays the heart. We need to have an applied anatomy of the mediastinum to understand EUS and EBUS in a better way. So these are the lymph nodal stations, and according to IASLC lymph nodal stations, see, 1 is neck, and 10 to 4 are accessed through EBUS. And mediastinal stations are 2 to 9. And in these 7, 8, 9 can be easily accessed through EUS, and 8 and 9 only through EUS. So let's take a question. Identify the station on this mediastinal EUS. It's between left atrium and right pulmonary artery. Okay, it's station 7, subcarinal node. So, coming to the indications of endosonography for the diagnosis of lung cancer, there are few indications where EUS only can help, like any lymph nodal masses in the lower mediastinum, or lung tumor adjacent to esophagus, or suspected left adrenal metastasis. There, EUS can help to get a histological diagnosis. So, and also EUS can help in posterior mediastinal lesions evaluation. So, comparing the technical aspects of EBUS and EUS scope. So, EBUS scope is thinner, but EUS scope has a wider range of visualization, and also because its diameter is larger, it is more stable. So, it's easy to do a sampling with EUS compared to EBUS. Although studies have shown that EUS or EUS done through EBUS scope, there is no difference in yield. And additionally, EUS done through EBUS scope is single operator and cost effective also. But if the target node is accessible by both EBUS and EUS, then with the same tolerable limits, FNB can be done with fewer doses of sedation, shorter procedure time, and fewer episodes of hypoxia. And also, EUS through esophagus complements EBUS and can lead to a complete medical mediastinoscopy. So usually the EBUS is done in supine position, and we gastroenterologists do the mediastinal evaluation in left lateral position. And here, in the neutral position, the transducer will be facing anteriorly, and it's the neutral position. So to turn the scope towards the right side, we need to turn to the clockwise direction, and to turn the transducer to the left side, you need to turn to the anti-clockwise direction. So through esophagus, we can do this through a station-based approach. Like we have 4 main important stations. That is lower esophagus near to GE junction, and we use a important landmark to identify that station. For lower esophagus, it's the IVC. It's the IVC. And for subcarinal space, it's the left atrium and the pulmonary trunk. And for aortopulmonary window, it's aortic arch and pulmonary trunk. So coming to lower esophagus station, so a schematic impression where the inferior vena cava joins the right atrium, we will have the station 9. So this is the EUS picture where IVC is joining to the right atrium. Here we will be having the station 9. Video. So this is GE junction liver. We have seen the liver, and now this is the portal vein, that anechoic structure. And this is the IVC, intrahepatic IVC. And now this IVC enters into the right atrium. Here, this is the right atrium. So here we will be having the station 9. So coming to the next station, that is subcarinal station. This is the schematic diagram. The subcarinal station is here. So we understand that it is between the left atrium and the right pulmonary trunk. So the left atrium and right pulmonary trunk. On EUS, you will see that there is a left atrium here and the right pulmonary trunk, and here you will be having the station 7, that is subcarinal station. So this is the left atrium, and this is IVC opening into the right atrium. And slowly pull the scope so that your atrium, left atrium comes into the center. And this is aortic trunk with this aortic wall. And now as you slowly pull and get the left atrium towards the left side, slightly towards the left side of the screen, this is a mitral valve. Slowly pull back. As you pull back, the right pulmonary trunk comes into the right side, and left side the left atrium will be present, and this will be the station 7. So coming to the third station, that is aortopulmonary window. So these two are the aortopulmonary nodes. So here, how can we approach this? This is like there are two methods where we can approach this aortopulmonary window. One thing is see through the aorta, descending aorta, and then you can do a anti-clockwise rotation and go see this aortopulmonary window. Or second is go to the subcarinal space and turn 90 degrees, where you can also find this aortopulmonary window. This aortopulmonary window will be there between this aortic arch and left pulmonary artery. So this is descending aorta. We are reaching now. We pull the scope to the aortic arch. As you do anti-clockwise rotation, you can see this aortic arch here and the left pulmonary artery. And this is second method, where from the subcarinal space, just pull the scope. You will be seeing the trachea as rings, and then do clockwise rotation 90 degrees, and again you will be reaching this aortopulmonary window, station 4L. So, and next comes the aorta and its branches. So aorta, as it branches into left subclavian and left common carotid, near to left subclavian we will be having station 2L, and distant from left common carotid we will be having station 3A, and we will not be able to see brachiocephalic because of the trachea in between. So this is the aortic arch dividing into the left subclavian artery, and we can trace the left subclavian artery for the lymph nodal, superior mediastinal lymph nodal stations. And additional advantage of US is assessment of liver and left adrenal for metastasis. So this is the liver portal vein, and as you trace the portal vein, it will lead to the splenic vein, and the splenic vein will lead us to the pancreatic parenchyma. And as you pull the scope clockwise, you will be seeing the adrenal gland as a seagull shaped. This is splenic vein, and this is the seagull shaped adrenal gland, which is hypoechoic. This is the. So identify this station on the mediastinal US, which we have discussed. So it's the aortopulmonary window 4L. So summarizing, knowledge of mediastinal anatomy is key for its evaluation, and subcarinal and aortopulmonary windows are the important landmarks. US or USB is complementary to EBUS in mediastinal nodal evaluation. Thank you.